I'm Dr. Dave Hindmarsh. Just to sort of go over what we've got, I would say about 50 minutes. So I'm probably going to get shouted at as I know we're a bit sort of late start. So I'll see if we can just sort of keep things back on track. If we're not careful or if we're not AI curious, we're going to miss out. Okay. And I think certainly in healthcare, no one's going to say that we've got buckets loads of time. No one's going to say that actually we can't benefit from this in terms of a primary care setting or even and any setting from that matter. But we need to be mindful though of the risks. Okay, I'm going to talk you through about how we've implemented it locally in our practice, and also about what you need to do. Bit about me, as with most professionals nowadays, certainly general practitioners, they have multiple roles. So I describe myself as patchwork GP because everything blends and helps into each other. I'm predominantly, and what I get paid the most to do is a GP partner at Eaglescliff Medical Practice where I work sessions. I'm also a trainer as well. I work for Hull York Medical School as the Associate Medical Director, which makes sure I look after medical students. I also work in our federation, Hartlepool and Stockton Health, HASH for short, as the digital clinical lead, which basically meant they wanted someone vaguely techie, nerdy, and somehow my name popped up. But yeah, it's fine. It's all good fun. Also run a couple of YouTube channels, which please feel free to talk to me about the margins. You must, though, cut out about 30 minutes of your time. Predominantly, the main one that I run is Doc Support Limited, which provides support for all things sort of digital. I've now teamed up with a good friend of mine, Matthew, who's a private practice GP. And so talking about how to get into that space. We'll also do a lot about optimization of your clinical digital systems as well. If you want to have a chat with me online because you found me too much, which is understandable, david.hindmarsh2@nhs.net. I loiter mainly on LinkedIn. Find me, Dr. David Hindmarsh, normally MORPh are very good at tagging me in stuff like that. I've worked with MORPh for the past 3 years, and it was thanks to my YouTube channel that they got in touch with me because I put a video up about my Red Whale application, which is something similar for GPs. I failed miserably, but someone from MORPh said, I saw your interview video. You look all right. Do you want to come work with us? And the rest, they say, is history. Conflicts of interest. I will mention Lexacom as an AI tool and sort of go into the dips and services. I've got currently a contract with them and doing a couple of videos with them, and so I am being paid by them. I will argue it is awesome though. Okay, who's using AI in their practice? Oh, go on. So we've got Heidi supporters on the table. Cool. They have dominated the market at the moment, I think, with their advertising. Anyone else? Yeah, so AccuRx have now got their inbuilt AI tool, which sort of they're trying to sort of push out. Who thinks AI is going to take their job? Nah, good. Would dispel that myth from the start. What do you think the government thinks about AI? Do you think they're pro-AI, anti-AI? Pro, like really pro, okay? And so obviously because there's that political will of they want to do it, that actually that will filter down to us, and obviously healthcare, the NHS being a huge part of a political picture. How often is the NHS used in any part of political broadcast? A lot, okay? So they've released the AI playbook, and we're going to go through sort of what their 10 points that they've done are. It's being mindful, aware of what the government wants us to do, because actually it will filter down to us. So principle 1, you know what AI is and what the limitations are. 2, you use AI lawfully, ethically and responsibly. We're going to touch upon that today, certainly in the healthcare setting, because I think what people are doing is they're using it and putting themselves at risk. But we'll talk about what you need to do, or at least your practice needs to do. You know how to use AI securely. You have to have meaningful human control at the right stage. We'll talk about the Hindmarsh sandwich. I'm going to beat about it enough that it will become vernacular. You understand how to manage the AI lifecycle, use the right tool for the right job, open and collaborative, and you work with commercial colleagues from the start, and you have the skills and expertise needed to implement and use AI, and you use the principles alongside your organization policies and have the right assurance in place. So this is the artificial intelligence playbook from the UK government, okay? The problem with AI is that it's not one thing. Okay, it's a minefield of loads of different, different types of computer programs in terms of how you think about it. And you've got you've got ChatGPT, that's a different type of model, say like to Heidi AI and blah, blah, blah. And you've got all these different competing things going on. And it's clear that it's very confusing from us who are not perhaps from a computer sciences background of like, what the heck are we actually talking about? The three that I think are actually important to us in a healthcare setting are these three. Okay, so speech recognition. So we're going to talk about, and really that sort of points down to ambient voice technology. I know that certainly Google and Apple have sort of come out with that automatic translation one. So you put your AirPods in and it's sort of automatic. I mean, for a healthcare setting, if that's proven to work and is efficient, amazing. Generative AI, okay, uses large quantities of carefully trained data so they can get your underlying patterns as well. So your large language models, think about your chat GPTs, and then your machine learning. Okay, so bucket loads of data. What the NHS does well for individual patients, they will have a mountain of data. Okay, but actually what we struggle with as clinicians is how do you process all of that and how do you make some sense and meaning out of it? Speech recognition. Talk about Lexacom, Heidi, Microsoft Dragon. That's not all of them, as you say. You've got AccuRx, Tortoise AI as well come out, and there are loads going on from this. So Lexacom have 4 products. Okay, they've got your ambient voice technology. So your little one goes around. Has anyone used Lexacom in the past just to do your letters? You dictate it in, it sends it off to its comprehension engine, so that's the name of their AI, and then it spits it back out there and then. Okay, so I can then proofread it and send it off. And then knowing the secretaries will still, because they're vigilant in their work, will still double check it, will still come back to me, but that rate of coming back is significantly reduced. So it had a massive impact on their workload. So where I am, Northeast, so we're predominantly a System 1 area, okay? And so when I joined Eaglescliffe 4 years ago, we were the only practice on EMIS. Interestingly, I'm from a military background. They use DMCP, which is an EMIS-based system. So when I went from military into there, I was like, oh, it looks all familiar. Anyway, we changed, thankfully, because of the communication, and it was getting dangerous. Because what we're finding is that all of our community teams were on System 1 and it would be a delay to get into us. And sometimes it wouldn't matter, but a lot of the time it would. So going back to your point on medicines reconciliation, not yet, but what I think is interesting is that a lot of the AI companies now, and I've seen it just from my own sort of social media feeds, is that a lot of them are focusing on letters. And then obviously the fallout from that is the medicines reconciliation. I know System 1 are working on an AI tool that sort of looks at a letter and hopefully does it. What I would love them to do is actually, as part of it, they do the medicines reconciliation, saying like, they've seen cardiology and they've said like, oh, the statin dose is now 80 milligrams. You've got it prescribed as 20. Would you like to alter? Yes, please. I think that would be a game changer, certainly for all of our workloads from that way. Okay, certainly with the amount of private Manjaro prescription going through, would you like this to add as a hospital prescription or an alternative one? 50p rant. We can do that one there, we. The one as well, what I'm sort of keen on is Lexicon Echo. So that is basically an automatic dictation function. Okay, so I can then just speak out loud and wherever I put my cursor, so Outlook, Word, 14 Fish when I'm doing my appraisal, speech to text, and it's pretty damn good. Okay. From my point of view, in terms of improvements, I save about 1 to 2 minutes per consultation, which you think, well, so what? That's not that much, but actually it's a heck of a lot. Okay, certainly as well, I'm guilty of that, having some consultations that are only 2 or 3 lines long. My documentation has certainly got bigger when I do use it. Okay, it's not about me. Our secretarial workload, so we are a 13,000 practice, 13,000 patient practice. Our secretarial workload is reduced by about 50%. Okay, so with my business hat on as a partner, going, well, hang on a second, I've got 2 very experienced admin staff who are now more free to do more work. Yes, win. Absolutely. Stupid things, though occupational health is important, my hands don't hurt. Sounds really pathetic, and I don't want to sound like a bleating sheep up here, but my hands ached at the end of the day. Certainly if I got a long clinic and you're typing up all those notes, the fact that just that low-level ache has gone, I'm like, yes. Right, key questions, certainly for those who've used it. Do you need to consent your patients? Hands up who thinks yes. Hands up who thinks no. Do you need to have a risk assessment in the form of DCB 0160? Oh, who's heard of a DCB 0160? Nope. Anyone heard of it? Oh, right, okay. Educate you on that one. So, does AVT need to be registered as a Class 1 medical device? And like, what the heck are you on about, Dave? Okay, we'll talk about that one. Does AVT need to have data protection impact assessment DPIA? Yes or no? Who thinks yes? Cool. Who thinks no? Do I need to have a clinical safety officer, CSO for short? Who knows what the heck a CSO is? So the answer to all of them is heck yes. I would like to use strong language. I've been told not to swear. Okay, so we'll go through these. Do you need to consent your patients? Absolutely, yes, you do. Okay, all I would say to my patients is, I'm using an AI tool. It helps me with my notes afterwards. I have seen some doctors who will consent saying you're more than welcome to have a look at them afterwards. But now with notes access, they can see it. I then document that consent. So I've got a short protocol set up. So I type in AVT and it will put a read code in, consent obtained, and then a preset text saying consent obtained to use ambient voice technology, open brackets, Lexacom, close brackets. Okay. The reason why I do that is that we've only been using this for 2 months' time. I'm planning to, he says, and it's recorded, so I will do it, audit the quality of notes and documentation because that is part of your risk assessment. If you're using an additional new tool, you need to be doing these risk assessments and auditing as part of that. Do you need to do a risk assessment? Well, I've given the game away. Yes, you do. Okay. DCB 0160 is a fancy term for basically the risk assessment for any technology that's new within practice, okay? And how you've considered the hazard log, the hazards that are available and how you've mitigated against those, okay? So Heidi table, have you had any, what do you think the problems with certainly these extra, you know, or like with Heidi where it's a separate system and then you're copying, pasting the notes in? Absolutely. So hallucinations is a big one, okay? And it falls back to how has it been trained, okay? So we've got, you know, I'm in a very, Northeast is very white. So actually I don't have any problems, but or certainly where my practice is to be that blunt about it. But if you've got different accents going on, different sort of, you know, English is not the first language, how good is it at picking it up? How has it been trained? Yes, it says it's all singing or dancing, but has it been trained and what model for? Okay, simple one. If you've got 2 programs open, have you got the right patient open? And I've seen that happen more than enough times. With my federation role, we look after urgent care, and the head of urgent care said, like, yeah, I've seen it time and time again, where it's clear that the wrong patient notes have been copied and pasted into. So actually that integration into whatever electronic healthcare record you're using is key for that safety aspect. Class 1 medical device, yes, it does. Okay, and that the UK is certainly the NHS is very difficult to get the Class 1 medical device registration and getting all that set up. You're engaging with patients. Some of them will prompt a suggested diagnosis as well. So as soon as you're having that interaction, at the very least, it needs to be Class 1. I wouldn't be surprised in the next couple of years, certainly in the next 5 years, where actually they offer more. Okay, so they're actually saying like, do you want to prescribe this, and giving you prompts that actually that class recognition needs to go up because they're doing more for patients. Okay. Does it need to have a DPIA? Yes. Normally every company is very good at helping you out with that. Do I need to have a clinical safety officer? This is interesting considering my background and how I'm interested in this. I only heard about what a clinical safety officer is within the last month, 6 weeks. Okay. And we're going to talk about that as well. AI-enabled ambient scribing products in healthcare and settings. What does the NHS accept? Complete the risk assessment. Now, what they haven't done, which I had to go at our ICB for, in a nice way, we're having a fruitful discussion, was they haven't got a list of approved providers. Haven't got it, okay? So the risk assessment falls down to either you as the individual, great, or the organisation you're working for. Okay, so if you're using this and you're not happy where the risk assessment is, it's down to you. So if it goes wrong, it's on your shoulders. Eek. Okay, DPIA. And also we talked about, and clearly GDPR compliant. Big one is, and why I steered away from Heidi, is that at the time that they approached me, well, two things put me off. At the time, my impression and understanding was majority was it American based in terms of the servers, whereas I believe that's changed now. And also when we had the sales rep in, they said that you didn't need to consent, and that just turned me off. I was like, nope, I know you're wrong. Admittedly, though, when they came in, that was before the NHS guidance came out. That is only a relatively new document because this is such a fast-paced moving area. That's only been in April of this year, there or thereabouts. If you want to future-proof yourself, get on your clinical safety officer training, okay? You do not have to be a doctor to do this. I'm going to say this again. You do not have to be a doctor to do this because it is clinician, any clinician. Okay, so what it is effectively, it's that middle person between, you've got external companies who are trying to flog the NHS stuff, end user, and you need to have the clinical safety officer in the middle, okay? What's interesting is that every large organization as well, all these new tech companies popping up, certainly in the healthcare space, have their own individual CSO as well. So get the training done. The NHS do offer the training, okay, so digital.nhs clinical safety, and just honestly, just type in clinical safety officer training and you'll find it, okay? I've currently got mine signed up with Ethos, a good friend of mine who we nerd out hard is the best way I can put it. He's also a fellow local GP partner, and we just nerd out hard together. He did his CSO training with Ethos. Okay, but if you got DPM, Digital Health Consultancy, they do large group training. So if you've got a group of at least, I think, 6 of you, they can come and do a 2-day package. Okay, talking about 400, I think my session with Ethos costs about 400 quid, all online, but actually it just protects me. Okay, so that I know then when people say about Eaglescliffe Medical Practice, clinical safety officers, like, yes, that's me, and I've done an accredited and approved training package for it. So if you're keen, or if you at the very least think like I am the tech guy that people go to, strongly have a look whether you need to do this. If you're then on LinkedIn like me and you're messaging all these other healthcare companies, actually them going, wait, you're a pharmacist and you're CSO trained, they'll bite your hand off. So think about your question. If they then came out with a medical reconciliation letter approval app, they go like, well, yeah, probably need a pharmacist at least to verify this. Snap, have it. Anyway, cool. Right, talk a bit about generative AI. Okay, ChatGPT is your classic example. We've just had our CQC inspection. I've got 3 kids at home, just done summer holiday at 2 weeks before the end of summer holiday, when I thought, right, I'll just have a nice ease back in before our medical students arrive for the year, get them all prepped up. Phone call comes, CQC. Anyway, still pending the results on that one. What it was useful for, and I'll show you a couple of things to have a look at. Crap, we haven't got a policy for this. My practice manager, who is 5 years off retirement, said, Dave, have you used ChatGPT at all? I was like, not really. She's like, I've used it for everything. She just went to town. I thought, fair play to you. So stuff that we were doing and, just making, but we just hadn't got it written down. So CQC were going to crawl all over it. We're like, right, we need to get this done yesterday. Okay. And that is a quick and easy way to do it. Medical education, who teaches students? Doesn't matter what flavor. Excellent. Right. I've got to honestly have a look at this. I use this and it's amazing. I'm going to talk you through the Hindmarsh AI sandwich. Ankit AI. If I'm on some of the GP partner Facebook groups, he's lovely. Like, he comments all the time. What he's done is he's taken ChatGPT and done a whole load of like GP primary care prompts over the top of it. It's all free as well. So that's Ankit, Kant.com. Okay. I think there's like a buy him a coffee stuff, but that is brilliant. So I've used that for like help what you're doing from that one. CliniBot, you do have to pay for, but as I said, I'm a GP trainer, but if you're doing regular clinical sessions, you can go into it and be like, I need some MCQs on this topic, based on these guidelines, can you help? And it spits it out. And you're like, yes. and it saves you, I would argue, 80% of the work. Why I'm not going to say 100% of the work is because of the Hindmarsh sandwich. Yes. He says sandwich so many times. Come on. There we go. Nice picture of a sandwich, just in case you don't know what a sandwich looks like. So my theory is that whatever you do, whenever you're using generative AI, when people get stuck, is that it must have the human bread before you use the AI filling. Okay? So you use your human going in with all your prompts and making sure that's all right. The AI will fill it up, and then you need to sanity check it before you hand that sandwich out. Where people get stuck and where it looks a bit crap is that people forget to check it on the way out, and they just hand it to you, and no one really likes an open top sandwich. Okay, we're not there yet. So last one, machine learning. Right, caveat this, I've done a lot of videos on System 1 on my channel. I am not sponsored by them. So who's on System 1? There are a couple of hands going up. Yeah. Have you seen the DNA tool that's up there? And there's a cancer detection one as well. Anyone seen these? Okay. So this one, pretty damn cool. Okay. What they've done is using machine learning is basically they've got a bucket load of data and gone, right, what's the likelihood of your patients, and you can set the date range. So like for tomorrow's clinic, what's the likelihood of them DNAing? And it gives you a very simple red, amber, green. We're like, that's quite cool. Okay. With the idea being that with your reds, that might trigger your secretary or your admin staff just to maybe, instead of just dropping them a text message, you might phone them, might nudge them a bit more than you would do. Okay, something that's quite labor intensive, but actually a DNA takes a lot of time. Okay, in bit. This other one, it's a cancer detection tool. So similar things. We said about the NHS has got a large bucket of data. So what they've done is they've taken a large subset of their population on System 1, gone, right, who out of all of these developed ovarian cancer, bowel cancer, bladder cancer, and they've picked up some more. And then they've gone retrospectively in the notes and saying what's gone on. So they've taken that data set and then applied it to your patients. So this is on those on System 1, this is there now. Okay, where it will spit out your top 10 at-risk patients for having cancer and give you a percentage. Are there any problems to this? Right, I'm going to caveat this. I love the idea, and I think this is where the future is, but I hate the execution. Hate's a bit of a strong term, but any problems with this? It's not on the patient notes. So it's on a separate part of System 1 where basically you set your parameters and it's got these 5 areas that you then go look at and it will spit out 10 patients. It doesn't record anything in the patient record, okay? Actually, in terms of our limited medical resource, we are then looking at these 50 patients out of my 13,000, probably disrespectfully from that way. I go way back to it. Like, where's the evidence? Yes, you've done this, and I'm not doubting the science behind it is in the computer science, but your biological science, there's no published data yet. Who's responsible? Am I responsible? As the designated, information governance lead, CSO-ish for the practice, like if you've got cancer and then you develop it because we didn't contact you, and then you put an information request saying, where was I on your list? Which you can do. We would have to tell you, but we didn't act on it. Is System 1 responsible or am I responsible? I honestly don't know. Big bit for me, evidence base. It's a great idea. Like, absolutely love the idea. And I do not want to dismiss it because it's clear how much work's gone into it. But actually, where is the evidence for this? Like, how do we communicate that with patients of like going, okay, by the way, this has come out that you've got a 3% chance of cancer. That's, as you say, 3 in 100. People like yourselves may develop cancer. The so what is then of, well, what do we mean by that? And they go, well, I don't understand what you mean. Have I got it or not? And some people think black and white, whereas as we know in this audience, statistics is very varied. So they don't give you where the percentages come from. Okay, so Northeast is a higher rate of bladder cancer. Okay. And what I can't, unlike Q-risk, for example, I cannot manipulate the data because you just spat out a percentage of going, well, is it because you've worked in ICI chemicals for 20 years and they've picked that up on the notes and that's what it's done? Or is it the fact that I've got a registrar who's missed out the fact that you've got a positive fit 2 weeks ago that hasn't been acted upon? I just don't know. So the actual information presented to you as the clinician is not there. Local guidelines, all very well, me going this, but if it's not on my 2-week wait pathway letter, I can't act upon it. I personally think it's a great idea, just executed horrendously. Okay. Anyway, right. So key take homes. Well, just thoughts, because you're all intelligent people. I don't like to dictate messages. Could you use AI a bit better in practice? Could you be using AI for your own personal work? And I think actually that hopefully give you a couple of ideas. And that's really, even though I'm giving a talk on AI, I know that I need to lean into it more to make myself more efficient. Okay. What are the risks? And have you mitigated against those? Certainly if you're patient facing. Is the device safe for UK NHS use? 2 questions based about the clinical safety officer. Who is your clinical safety officer? If you don't know, find out. If you haven't got one, could it be you? Because if you've sat here, there's probably an ounce of like, oh, might be interesting. And can you learn how to use this safely? Fab. That is me. Shortened it down. Any questions for me? Here we are. So I just used Echo. So we had all the products in, we had all of this, but I was a bit like, and even in my practice, exactly the same, like people weren't comfortable using the AVT, their choice. It was like, right, okay, well, at least use that to speed up typing your notes. We've got the microphone sat in the corner, they provide you one and going like, right, hit plus, patient see me today, blah, blah, blah. I then went on to using the letters and then only recently with the AVT. You can do it yourself, as in do a consult to yourself. It's like, oh, hello, Mr. Smith, I can see and see what it spits out. And I've done that. I've got a video of me recording a little Hulk figurine for it. Tragic, but true. But yeah, it's. I agree with you though. It's that practice and where you feel comfortable with. But that's why I like Lexacom, because I could start with Echo and at least get some benefit out of it. So, what do I use? I'm going to be honest with you. It's one area that I know I need to get better at. And there's one that I don't have a preference for because I haven't explored it enough. But I know certainly with my better examples of probably like creative work that I do. So I use Canva a lot for a lot of the stuff that I put out on social media. And so that will have an AI picture generator that I use a lot on that one. And again, the ones that I do use in terms of CliniBot, I think is a ChatGPT base where they've just got a med-ed prompts that they've put over the top of that one. So certainly for us, how we've started to do it is that we use System Connect. We've got away with eConsult, but again, with the idea being that you can either online or over the telephone and the receptionist effectively types it in. But then, as you say, we've kept the information required quite light, because actually what we found is that certainly with eConsult is that you get down a rabbit hole. And so suddenly you're in this chest pain pathway and they can't go any further. I worry, though, that actually for the safety cases of those triaging tools to be put forward, it's going to take years. So actually, like, it's a good idea, but I sort of worry about actually, is it safe to use in practice? Change management within primary care. Okay, so I think what I've found is one, it surprises you. Okay, so one of our biggest users of AI, and the first one who really took it up was our senior partner, who's due to retire in 5 years' time. She was like, Dave, this is amazing. I could just talk and it does it. But she uses Echo a lot. I think, though, with any change management, you get a point of there are some people you can convert by just talking about it and saying, like, here are the opportunities, this is what we can do, blah, blah, blah. And that's one group. I find they're very rare, though. I think you have to demonstrate, certainly in the PCN, you have to demonstrate the change, and then the others will follow suit. You'll never get everyone moving at the same time. Okay, so we're probably one of the first. Think about our PCN. We're just purely on Lexacom for ambient voice technology. But I think it's that change management, and that's with anything, not just AI, that you need to balance it out from that way. So I always think that you'll need someone who spearheads it, and you'll need to be someone who is like, yeah, who's your Dave in your practice or in your PCN, be like, run with this. And then they can communicate going like, this is what we've done, and document and evidence your savings. Okay. And then the others should hopefully follow suit. Well, thank you very much for your time. I hope that you found that useful. I will be loitering around for some of the day. As I said, I'm on LinkedIn. Feel free to drop me a message. david.hindmarsh2@nhs.net. It'll pop up at Eaglescliffe Medical Practice, and then take it from there. Thank you very much for your time on this Wednesday morning.